Between the years 2000 and 2015, global health metrics recorded a period of rapid, significant improvement. Child mortality plummeted, and major infectious disease rates dropped sharply across almost every measured demographic. According to the World Health Organization's 2026 dataset, that momentum has hit a wall. With less than 5 years remaining until the 2030 Sustainable Development Goal deadlines, progress has reached a standstill. The 22.1 million excess deaths associated with the COVID-19 pandemic certainly caused a severe disruption. However, the data shows that missing the 2030 targets is the result of a mathematical system failure that began prior to the pandemic. We can measure this shift through the Universal Health Coverage, or UHC, Service Coverage Index. This is the primary metric the WHO uses to evaluate the overall capacity and delivery of global health systems. This measures the Universal Health Coverage Index. Between 2015 and 2023, the global score barely moved, climbing just 3 points from 68 to 71. Look at the minute difference between those two global bars. In the previous 15 years, the index gained 14 points. That 3-point shift represents a severe deceleration. The rate of progress has slowed by roughly 2/3 compared to the years leading up to the Sustainable Development Goals. To understand why the entire global health apparatus is missing its targets, we have to look inside the components of the UHC index and locate the system-level bottlenecks. This deceleration signals that the rapid gains seen in the early 2000s have been replaced by a persistent structural leveling off of progress. The clearest way to measure a health system's output capability is through routine childhood immunizations. This chart displays global immunization rates. The orange line, representing the DTP-CV3 vaccine, has flatlined at approximately 85% since 2015. And the dark blue line tracking the second dose of the measles vaccine sat far below, at just 76% in 2024. Epidemiologically, 76% coverage is mathematically insufficient to achieve herd immunity against a highly contagious virus. This specific immunity gap is a direct product of systemic delivery failures, and it is actively fueling rising measles transmission vectors around the world right now. What we are observing is the last-mile paradox in service delivery. Vaccinating the final 15% of a population demands exponentially more labor, resources, and tailored outreach strategies than reaching the first 50%. Our current health architectures are built for broad, low-friction deployment. They are not currently equipped to close these remaining, highly complex gaps. The UHC index is stalling because current health delivery mechanisms have reached their operational limit, exhausted by the complexity of the populations that remain unreached. We see the exact same fracture when we look at infectious disease incidence, which reveals how a plateauing delivery system handles complex pathogens. This chart compares tuberculosis incidence rates globally and by region. Look at the global average here, in the middle. We still see a 12% decline in new TB cases from 2015 to 2024. But if we map that downward slope for TB against global malaria cases, the trend lines diverge entirely. Malaria incidence has increased by 8.5% over the exact same period. The global malaria burden has climbed to 64 cases per 1,000 people at risk. The trend is actively moving away from the 2030 reduction targets. Even for diseases with successful interventions like HIV and TB, the current velocity of case reduction is entirely decoupled from the mathematical curves required to actually hit the 2030 goals. Diseases with mature, vertically funded infrastructures are improving slowly, while broader preventative care networks are fracturing. The underlying health systems simply lack the structural capacity to handle both at once. Both the plateauing immunization rates and the rising disease incidence are downstream symptoms of a severe scarcity in foundational inputs, labor and capital. The primary constraint dictating a health system's capacity is the density of its skilled workforce. The global distribution of medical personnel is heavily skewed. The European region maintains 40 medical doctors per 10,000 people. In the African region, that density is barely 3.1 per 10,000. That region handles 65% of the global HIV burden and the world's highest malaria rates, while operating with a fraction of the necessary workforce to deliver care. Alongside that labor deficit is a severe capital friction, manifesting as intense financial toxicity for patients at the exact point of care. Right now, over a quarter of the global population faces financial hardship, entirely due to out-of-pocket health spending. Out of an 8 billion global population, 2.1 billion people face direct financial hardship from medical costs. Within that group, 1.6 billion people are actively living in poverty or have been pushed into poverty by those exact expenses. For low and lower middle-income countries, the critical pillar of capital required to offset these costs is official development assistance, or ODA. But official development assistance for health is estimated to drop by 30 to 40% between 2023 and 2025. This rapid reduction in capital triggers immediate, cascading failures across the board. Clinics lose funding, education programs pause, and medicine supply chains fracture. The UHC index cannot mathematically increase as long as the global health architecture bleeds capital through out-of-pocket patient costs and starves its own labor force. These system failures lead to a central paradox. The global health community is attempting to optimize a system it cannot accurately measure. We can establish a baseline by looking at global mortality. In 2023, there were approximately 61 million deaths worldwide. Out of those 61 million deaths, only 21 million were reported with a cause, and just 12 million of those were assigned meaningful ICD-coded cause of death data. This is a crisis in civil registration and vital statistics systems. Currently, 32% of countries have never submitted cause of death data to the WHO. This void creates an immense operational hazard. Without comprehensive empirical mortality data to observe, global resource allocation is forced to rely on predictive modeling instead of actual observed outcomes, which brings us back to that universal health coverage score of 71. The severe workforce shortages, the out-of-pocket financial toxicity, and the vast unmapped data void are acting together as a hard, absolute ceiling on that score. The 2030 SDG targets are mathematically unattainable if the world continues to rely solely on vertically funded, siloed disease interventions. Restarting the momentum of global health requires abandoning isolated metrics. The data shows we must pivot our resources toward rebuilding the foundational